a lot of places you could have been tonight, and you're here and interested in sleep, and certainly that's an interest of mine. I've even read somewhere that it's a passion of mine. I don't necessarily think in those terms, but it's something that I've been involved with for a while. I see some faces that are familiar, so I saw on my LinkedIn that I've been here for 20 years. I'm celebrating my 20th year in Moscow, so I guess that's a while. You shouldn't read your own press results, but at any rate, the matter of sleep just kind of came as a serendipitous thing for me. Coming here, there was no one doing sleep, and so I volunteered, and one of the first things we did was to do a study in the Moscow clinic office, and found that 60% of people that were coming to the doctor for other causes than sleep had sleep problems. So fairly prevalent that people have sleep problems, and so we wanted to do something different tonight, and so you guys are kind of part of an experiment. We wanted to make it useful to you in terms of assessment. So you saw some tables around here, so not only are we going to feed you, but we're going to try to make it as useful to you as possible. So in order to do that, I kind of need to know who's here. People with sleep problems usually kind of come to sleep talks because they're worried about themselves or maybe someone else. You know, so sleep problems are a real interest. So how many of you here thinking about things that are concerning for a loved one or someone else other than yourself? Okay, and then others I would assume are here because you have some sleep issues of your own. There you go. Okay, okay, good. And you know, sleep problems can come in a variety of different categories. There are people that sleep too much and people that don't sleep enough. So if you have problems with not sleeping enough, let me see your hands. And if you have problems with sleeping too much, okay? And some of those people can be having both problems, for sure. So the way that we categorize sleep is based on a lot of things that have occurred during my lifetime. And sleep, as a sleep entity, as a specialty, has really occurred quite recently. I well remember watching surgery. I was at University of Texas, and I got to see DeBakey. If you anybody remember the name of DeBakey, one of the first cardiac surgeons, I guess he did the first heart transplant. And I watched him do surgery, and that was in the 60s. And sleep apnea and sleep medicine really hadn't even occurred. In the 50s is when we learned about REM sleep. So that's fairly recent for some of us. And that led to people thinking, well, maybe sleep would be useful for studying dreams. Post-World War II, kind of a Freudian period. So the first sleep research was actually done by a psychiatrist. And it turned out not to be something that we spent a lot of time learning about or doing much with. But at any rate, that was where sleep medicine had its onset. And then it later became the issue of narcolepsy popped up, and it went from the psychiatrist to the neurologist, and that centered the sleep in Stanford. And kind of interesting little side note that the people at Stanford wanted to study people that were learning about sleep, so they took a very keen interest in Moscow and came out and watched us and helped do the study that I mentioned that we studied, and found that 60% of people coming into a doctor's office really had sleep issues that were not being addressed. So that was kind of that thing. And then the next thing that came up was was sleep apnea, which turned out to be the big part of the iceberg under the water, and that didn't really occur until the 80s. So sleep apnea turned out to be the big issue. So we're going to do some assessments tonight and help people kind of decide what would be perhaps the next step in relationship to sleep problems. There are basically 5 different categories of excessive daytime sleepiness being one of them, obstructive sleep apnea, insomnia, can't sleep, and narcolepsy being a person that has a real disorder neurologically that's been able to find ways to be treated as well. So I wanted to let you know that your questions, if you have something that you're interested in, please let me know, because that helps me to direct my talk toward something that you're interested in, not something that I'm interested in. There are over 89 different diagnoses in the field of sleep medicine, and we're not going to cover all of them tonight. But I would like to cover the ones that you have an interest in, and just to kind of set some categories. REM and non-REM are the 2 main features of sleep, and that is dreaming sleep as well as non-dreaming sleep. And we study that based on what we call a polysomnogram, or a sleep study. And with the research that we learned from that, we got quite a bit of information about how to take care of sleep, and we talk about sleep architecture, which is the amount of time people spend in the different stages of sleep. And we have 1, 2, 3, and 4, and then people go into REM, and then they do it again. So the average person is going to do that. Got to keep my mouth wet, talking dry. The average person does that 5 to 6 times a night. So one of the questions that people often will ask me is, how come I wake up during the night? And one of the things I like to tell them, well, it's normal. A normal person's going to wake up 5 to 6 times in the night, but the key is just to arouse, but not to awaken. So I have some people that I call my great sleepers, that I always ask them, well, how is it that you manage to sleep so well? And they say, well, when I arouse, I just don't open my eyes. I just keep them closed and go back to sleep. So that's actually a good way to be an Olympian sleeper, is when you arouse, don't let yourself awaken and alert. But some people will have insomnia, and there are lots of ways to treat that. We're going to be giving you some information that talks about sleep hygiene, basically the methods of having a good sleep environment. But that, I think, can be really helpful. One of the things that I was taught early on in my sleep career was by a guy that was the fellow that we call the grandfather of sleep medicine. His name is Bill Dement, and one of the things that he taught me early on was that, well, if you go to talk to people and they're falling asleep, it's not because you're boring, it's because they don't have enough sleep. So insufficient sleep turns out to be a big problem. People just don't give themselves enough time to sleep, and don't sleep well, and that can be a problem that compounds itself. So a lot of the studies that were done on sleep did what are called multiple sleep latency tests, which is a series of 5 naps. And a person who's had a normal night's sleep, somewhere around 8 hours, women can sometimes get by with less, but in general, we're talking about 8 hours of sleep. a person won't fall asleep in a 20-minute opportunity for a nap. So the 20 is a multiple sleep latency of 20 is that's as good as it gets. But some people fall asleep, well, within, a couple of minutes. And that's a very rapid sleep latency. Anything under 8 is considered to be consistent with the diagnosis of narcolepsy. And then if they fall into REM sleep immediately, that's called a SOREM, short onset of REM. And it takes 2 naps to get a diagnosis of narcolepsy, unless a person has cataplexy, which is a failure of waking and sleeping. So a person that's awake falls asleep and falls down. That's cataplexy. So sometimes they just will nod their head a bit. But at any rate, so if we're getting enough sleep, we don't have a problem staying awake. But if you got a problem staying awake, then that's excessive daytime sleepiness. And that turns out to be a very serious problem, and one that we have a lot of solutions for, and one that we're learning more and more about. Turns out that sleep, we used to think of sleep as kind of like putting your car in the garage overnight. I was thinking about that, but it really would be more like, if you use that metaphor, it'd be like putting your car into the service department of the person that made your car and have it serviced overnight. It's more than just changing the tires and rotating them and doing an oil change and things like that. I mean, sleep is very, very important to our daily activity. And when we're not getting enough sleep, we're not getting the cellular rejuvenation that's so important to sleep. Some of you probably came and heard my colleague, Dr. Geidel, talk about the effects of biochemistry and bariatrics, and a lot of people that have problems with obesity also have sleep problems. So we've enjoyed a collegial relationship, sending people back and forth to one another, because often not sleeping can affect your insulin metabolism and a lot of those other issues as well. So that is one of the complicating features. So from that, we were wanting to do what we call a stop bang. And it turns out that that's a screening method that can be used to help find out people that have obstructive sleep apnea. And I've been working to introduce that concept to people that work with people and screen people. That stands for snoring, tired, obstructive symptoms, which can just be kind of gagging and choking when a person's trying to sleep, or somebody observes a person to have an apneic episode, sees them stop breathing. So a lot of times spouses are giving that information to us. They're letting us know that, well, my husband stops breathing at night and I have to get him going. The P's for blood pressure, so STOP, and then BANG. B stands for body mass index above a certain level. And many of you might know what your body mass index is, but if you don't, we're going to give you an opportunity to find out what it is and see if that is another point. Age above 50, that's the A. N is a neck size greater than 16 in a woman or 17 in a man. And G is gender. That stands for men get a point, women don't. So the highest a woman would make would be 7 out of 8, and the highest a man, 8 out of 8. So that's a screening factor that we're using now to decide who might need further study in relationship to obstructive sleep apnea. So we'll create a way for the people that, if you don't know your blood pressure, we'll help you find it. And if you don't know your neck size, we can measure it. If you don't know your gender, we're in trouble. We'll do the best we can. So, at any rate, am I hitting on some topics that are of interest to people? Okay, well, if you have anything that you want to insert or question you want to ask, we'll stick it up and just we'll get to it. Somebody asked me as we walked in if I've treated my sleep apnea and I'm doing it the way they're supposed to. You know, I take my machine in and they look at it and find that I'm actually sleeping, but I'm still sleepy. What about that? Well, that is a medical condition that we have identified. Persistent, excessive sleepiness after treatment of sleep apnea is one of the things that we will treat for. And we use the same kind of treatments that we use for excessive daytime sleepiness causes. A lot of times people have excessive sleepiness from circadian rhythm disorders, which is a whole other category. I'm actually suffering from one of those circadian rhythm disorders right now because I've been in Hawaii for the last week, and they have a different time zone. Now you guys are feeling sorry for me, right? I appreciate that. No, just having your circadian clock be altered can leave you sleepy, and it can actually lead to a whole variety of medical problems that include hormonal disorders, mood disorders, the handling of insulin, insulin resistance. Those kind of medical disorders can be because your clock's fouled up. And your clock is in your brain at what's called a suprachiasmatic nuclei. It's okay to call it the SCN. But your eyes cross. You probably know that one side of your brain interprets vision on the other side, and that cross is called a suprachiasmatic nuclei, and that clock is sitting there. And some people just have a really easily dislocated clock. Students, especially, teenagers. You might be seeing a lot in the literature or in the newspaper about people talking about having school start later, and that turns out not to be a bad idea, because kids at that age often have a hard time waking up in the morning. They can't go to sleep until midnight, and then they can't wake up until 8 or 9 because they have a delayed sleep phase syndrome. And of course, we live in a farming community, and the opposite of that is an advanced sleep phase syndrome. Those are people that go to sleep at 7, and by 3 in the morning they're ready to wake up and go milk the cows. And that's an advanced sleep phase syndrome. Then you can have a irregular sleep-wake syndrome, where your sleep is all gotched up and you don't sleep you don't have a regular wake-up time, you don't have a regular go-to-sleep time. Or then you can go travel and go across a few time zones, and you'll end up with a circadian rhythm disorder for traveling and going across time zone. So those are different things. There's shift work sleep disorder is a person that can't adjust to shift work, and we see those as well. So the circadian rhythm disorders turn out to be a cause of insomnia, and the other one that a lot of people have is restless leg syndrome, and that's a disorder that's not been real well recognized until actually we were working on it when we first started doing the sleep center here at Gritman. But what really kind of turned it around was when they discovered a medication to treat it, and so then all the drug companies grabbed it and put it on TV. So a lot of people now know about restless leg syndrome that didn't used to know it. But it's basically just a sensation of discomfort in the legs that causes you to feel like you have to move your legs. It's very interesting. It's not really pain. It's not a problem of pain, it's a problem of discomfort. And that discomfort is relieved by movement. And it usually occurs in the evening when people are tired. And the movement relieves the problem. So those are the criteria. We use primarily dopamine agonist to treat it. And that is probably what you've seen on television is one of the companies that makes a dopamine agonist talking about restless leg syndrome. So at any rate, the only assessment we're going to do for that is just to let you know about it. And if it is a problem that you've been having that you weren't aware of, well, you might need to see your primary care physician and mention it. A lot of these things come to the attention of family doctors when somebody walks in and says, "What's this going on here? I'm not sleeping enough. I'm not getting enough sleep. Or my legs are bothering me at night." And that really helps us as primary care doctors to have you bring that to our attention. There's a condition called PLMD, periodic limb movement disorder, which is really more of a problem to the bed partner than it is the person that has the problem. That's when you just have this rhythmic kick, and it's hard to sleep with. Some people wear out the sheets in a certain particular portion of the bed where they kick. I well remember a patient that told me, you know, I within the very short period of time I have to buy new sheets because I just have a hole that comes, and then I kick the hole and rip them, and they have to be replaced. So that's PLMD. But if you're a spouse that's got the problem, then you're being kept awake by somebody kicking you. Of course, there are lots of medical problems that have insomnia associated with them. But the biggest cause of insomnia that's not treated by the medication that you're trying is usually sleep apnea. So if a person's being treated for insomnia and they're not sleeping through the night, they're waking up through the medication they're taking, they often have obstructive sleep apnea and need to be treated for that. Need to know that they got obstructive sleep apnea, and that can be taken care of. Probably the easiest way to treat sleep apnea is stay off your back. Probably people that know someone that they're sleeping with or that they're observing sleep, and they notice that they fall asleep, they'll probably notice that they're falling asleep when they're on their back. If they stay on their side, they actually do okay. I often read polysomnograms that say, you know, the person in the supine position, or lying down, supine is on the spine. That's the way I remembered that from medical school. At any rate, if you're having that problem when you're on your back, well, and you can stay off your back. Of course, a lot of people say, well, you know, I have a shoulder problem, I can't lie on my side, and that has to be addressed too. But that is probably the most common method of treating snoring and sleep apnea. So, the other methods for treating sleep apnea can occur. We do move the jaw forward. So if you move the jaw forward, you open the airway. So your tongue's actually connected to your chin. So when you stick your tongue out, you're doing this, and the airway sits over it like this, and if you move the jaw forward, you open up the airway. So you see dentists getting involved in the whole scheme of treating sleep apnea, and they're moving jaws forward to help open up the airway. So, and then the other thing is positive airway pressure. That was actually discovered, like I said, in the 80s, when a guy in Australia had a patient that had sleep apnea that was so bad he was obviously going to die from it. And they offered him a tracheostomy, which would work. You bypass the obstruction, so they used to treat sleep apnea with a tracheostomy. So he was on the way to a tracheostomy, and they said, well, we don't want to do that. We'll just take what comes. And they said, well, you mind if we try seeing if we can open the airway with positive pressure? This is in Australia, so I don't know, they use duct tape, but if it had been in Idaho, I'm sure they used duct tape to put the mask on to keep the airway open, and sure enough, when they got to a certain pressure, the sleep apnea just went away. It was completely gone. And then they decided, well, let's let it, let's move it back and forth. And they moved it back and forth, and sure enough, when they got at a certain pressure, the airway would open, and this guy would breathe, and it provided a very incredible laboratory for studying the effects of sleep. So a lot of what we've been able to learn has been because we can see what a person's blood pressure is and then correct it, and then blood pressure goes down. So one of the things we find is that people that have very difficult to treat blood pressure actually have sleep apnea. So that'll be something that we'll work on helping people assess with the stop bang. So let's see. Yes?
If you look around the room here, you notice there aren't very many 20-somethings here. Is difficulty sleeping to some degree a natural part of aging, or should we in our 60s be sleeping as well as we did in our 20s?
Good question. Turns out that the person in their 60s needs just as much sleep as the person in their 20s. Actually, the person in their 20s not getting enough sleep because they're having too much fun, but the person in their 60s needs sleep, but the characteristic that we have identified in studying aging sleep is fragmentation. There's more fragmentation of sleep, more easily aroused, but the sleep is actually often will come at different times. The person that has gray hair and is retired can take a nap, and it turns out that the sleep that you get, the Europeans do it with a siesta. They sleep 6 hours at night, 2 hours in the afternoon, but they're getting their 8 hours, and that is okay. I mean, it seems that the duration of sleep, the amount of sleep that we're getting, is the important thing. So people need to get that 7 to 8 hours. And a lot of what we do in our hectic, fast-paced life is not oriented towards sleeping. I mean, we've actually done studies that show that people, when they go camping, get a lot better sleep. Then they're away from all the light, and they're away from the noise, and they're away from the pressure, and they're away from what all the different things of ordinary life are. Can you prescribe you a camping trip or put you on CPAP?
Have you mentioned psychological, like suppose you had a rough time as a child, your house was disruptive, there were problems and you never slept well, and so what about psychological? Do you treat psychologically very often?
PTSD, post-traumatic stress disorder. That's the way we categorize that thing. Actually, interestingly enough, another good thought. This past year, we have a book of DSM-4, 5, whatever, which is the diagnostic manual of whatever, psychological disorders. The PTSD was actually changed from being a psychological problem to being a sleep problem. So now, people that have had traumatic events, whether they were in war or whether they were in their family and just got treated badly, they are now considered to be a sleep disorder, not a psychological disorder, because it's not a person that has an abnormal psychology. It's a normal person that was exposed to a harrowing event. Might have been being abused or treated badly or all those different things. But we do have medications that are helpful for that. And it turns out that one of the medications we use is a medication that's actually a blood pressure medication, and people that were in troops and being treated for blood pressure were found to be doing well on this particular medication, and their flashbacks went down a tremendous amount. So we started using that medication for PTSD, and it's been effective. It's been effective for people, and it's not everybody knows that, but I should mention the fact that I don't learn any of this stuff in medical school. They teach you nothing about sleep in medical school. But it's a lot of it just is the recentness of the information. I don't think they're doing a lot better job now with the kids that are coming out now than they did when I did, although they are doing some better, and they are teaching about sleep to some extent. But it's still not necessarily something that your primary care physician is going to have learned of, and don't give them too hard a time for that. Actually, one of the, I ran across some great teachers in my many years of schooling, and one of the people I remember so fondly is a woman that was a chemistry professor, and she made us say at the beginning of class, chemistry is easy, chemistry is fun. Chemistry is easy, chemistry is fun. And I think that that's what happened to me when I started learning about sleep. I thought, my gosh, this is a whole mountain of information. But I thought, well, sleep is easy, sleep is fun. And so I just piled in and ended up having read all the books and gone to numerous courses, ended up being able to pass the boards and become a sleep doctor. So, at any rate, I don't know why I thought of that. Just one of those little things that jumped into my mind. But it's a good way to look at new learning. Yes?
Can you discuss a little issues with falling asleep?
Falling asleep when you don't want to?
No, issues
How to fall
wanting
asleep?
to fall at rest.
Yeah, that's a great.
And maybe a follow-up, just your thoughts on different medications.
Okay. Falling asleep is something that's natural. It's the way your body's made. So you're made to be awake 2/3 of the time and sleep 1/3 of the time. And when I mentioned earlier, when you don't do that, your body is not functioning properly and it's not cleaning up the mess. Turns out you have no lymphatic system in your brain. You have lymphatics in your body, and those lymphatics filter, take the breakdown products of the mechanics of living and put them through the liver and the kidney and filter out all those bad things. But that doesn't happen in your brain. But what does happen is when you go to sleep, your brain opens up channels of circulation and allows the CSF, the cerebrospinal fluid, to go in there. And I just think of it as like it washes your brain. And then it is put into the lymphatic system, and then that lymphatic system clears all those particles out. So, so falling asleep is something that we find that people do. There have been a lot of experiments. You can't make people stay awake first longer than a certain amount of time, and you're going to fall asleep. And one of the things that helps people with insomnia is to realize that you can't, well, there's only one genetic family that has fatal insomnia. So, and if you're not in that group, you don't have to worry about it. So most people that are worrying about insomnia are worrying about something that they don't need to be worrying about. So most of the things that we teach people to do to help them sleep is to help them stop trying to worry about something that's going to be a natural process. So we call it cognitive behavioral therapy. And we teach people to put your mind on something. You give your mind something to do so it doesn't go around finding things to upset you about being awake. So, yes.
I have, my problem is worrying about not sleeping.
Right. So you don't have to worry about it. That's what I just told you. Stop it. That's a technique used by Bob Newhart. If you find you're doing something that you don't want to do, well, just stop it. But so we teach people abdominal breathing. Take some nice deep abdominal breath. And you find that your diaphragm is going down and you're not using your chest, and you relax it and relax your, you can start at your toes and relax your toes, and then relax the balls of your feet and relax the arch of your foot and relax your heel, go all the way up. So we do relaxation training. We do thinking of a pleasant place that you've been, mental imagery. I can think about being on the beach and all of a sudden, it's kind of like, sleepy. The other thing to do is, well, I got a little thing that, got all these little sayings on it. It says if you're having trouble sleeping, don't count sheep, talk to the shepherd. I like that. But so one of the things people can do is use scripture. Repeat the 23rd Psalm, given a second to each word. So you're giving the mind something to do, and in doing that, you take it away from trying to be involved in a process that it shouldn't be messing with. We have the sympathetic system and the parasympathetic system. That's the part of the body that works automatically, as opposed to the part of the body that we work through saying, squeeze your fingers and look like you're squeezing a tennis ball. But the parasympathetic system is saying, breathe, don't breathe, breathe, And that, so when we get that gummed up, we keep ourselves awake. So there are people who do work in that area. There's a really good class, insomnia, at WSU that we've sent people to go and learn techniques of going to sleep. I mean, their hypnosis is a way of putting the mind to work, doing something different, watching whatever they do. I've never been hypnotized, but it works for some people. Some people have actually used hypnotism in sleep. We use tapes. Go on the internet and go to, I like to give people good websites to go to rather than just going to goofy ones, but One that I like is the National Sleep Foundation, and it's called sleepfoundation.org. So just small letter, sleepfoundation.org, and you can find information and different things that you can have access to help you with that cognitive behavioral therapy. Any other questions that are popping? Here.
I went through the sleep center, and I'm 10 on a scale of 20 of sleep apnea.
Uh-huh.
And I'm more interested in the mouth guard than
Uh-huh.
the CPAP. How do you feel about mouth guard?
I think the mouth guard is wonderful, very, very effective. I think that if you get it made by your dentist, you're going to get a smaller, more compact, nicer fit. But at that sleepfoundation.org, they actually have 2 devices that have been, I like to say, vetted. They've been vetted by the FDA and the American Association of Sleep Medicine. So they've been looked at, they've been studied, and they're shown to be effective. They're kind of a boil and bite technology. You know, just like the mouthpiece that kids use to keep from getting their teeth knocked out. But they allow you to move the jaw forward just a millimeter at a time. And one of them uses a little Allen wrench that can move it forward, and the other one just uses a millimeter against millimeter and you just push it forward. But you start with a neutral position, just with your mouth slightly open and your jaw in a relaxed place, and then move it forward. And that moving it forward does the thing about moving your airway open. So I think for mild to moderate sleep apnea, it's very effective. There's a dentist in town who has been working diligently. He uses ultrasound to measure the airway opening space. And I've probably worked with him several dozen patients, and does a very nice job.
What is his name?
Hansen, Clay Hansen. Yes?
A question about caffeine. I think most people know, or at least think they know, that caffeine can keep you from falling asleep.
Mhm.
But can caffeine use cause you to wake up even if you're falling asleep? No, caffeine used during the day cause you to wake up at 3 o'clock in the morning?
I don't think so. I think the duration of action of caffeine is shorter than that. But if you're drinking too much, then you're stimulating that sympathetic portion of your body so much that I think it can affect your sleep at other times. I mean, so drinking excessive amount of caffeine is it's a stimulant. It's a stimulant. We used to use it to treat narcolepsy, because it's a stimulant. So when people that have narcolepsy usually use a series of daytime naps and maybe caffeine and maybe Ritalin or methylphenidate or Adderall or modafinil. All those are all medications that we use for that. And you said something about the different kinds of sleep medications. I think I didn't cover that. Probably Tylenol PM is the most commonly used over-the-counter sleep aid there is, and if that works, great. If you're still sleeping, you probably need something other than that. There's Unisom, and if you read the label, you're probably finding that you're basically using some of a Benadryl type product. But doctors have access to sleep medications that are very effective. And again, if you're taking a sleep medication from a physician that's a sleep medication that is designed, they're all designed to basically potentiate the relaxing part of the brain, which is mediated by GABA, aminobutyric acid. That is what helps your mind shut down. So if you take a medication, and there are lots of them, then it potentiates GABA and it potentiates that going to sleep. And if you're still waking up in spite of that, then you need to be sure you don't have sleep apnea. And we probably would want to do a sleep study on you and look into it a little more aggressively. But there's Ambien. Ambien is a non-benzodiazepine sleep agonist. It's an agonist or a potentiator of GABA. And it's very effective, and it's been used extensively, and people have had side effects. All drugs have side effects. So any medication you take has got side effects, and the job of your physician is to find something that's more effective for its effect than side effects. So that can be tough, but there are benzodiazepines. That's the category that has Valium and Xanax and lorazepam and all that kind of thing. So I hope this is helpful. Yes.
I haven't been able to sleep for quite a while, about 40 years, slept all night. I've been to the VA sleep study twice, flunked, can't go to sleep when I get there.
Oh, you stay awake during the study?
Yeah, can't go to sleep. I mean, they get all the leads on your legs, chest, arms,
Yeah.
put the mask on, and I can't go to sleep.
Have you ever had trial CPAP?
Well, part of it was with the mask,
Mm-hmm.
and pretty soon about 3 o'clock in the morning, I get up and go home. And, I mean, I honestly don't know what to do next.
Well,
I mean, I don't know what else is out there.
yeah, there are other different ways of treating sleep apnea than position, mandibular advancement device, and CPAP. Sometimes we use stiffeners in the palate. There are ear, nose, and throat procedures, but I'd be glad to go over it with you and see you. It sounds like, they're not only is there positive airway pressure, there are things that can put negative airway pressure. So they basically open your airways with suction. So I don't think you should give up. But have you seen a sleep doctor?
Just
Okay,
at
one.
the VA.
Yes.
Leg cramps.
Leg cramps, okay, good. Well, leg cramps are often confused with restless leg syndrome. Leg cramps are their own entity. That has a number in the diagnostic manual. Most often it's an electrolyte abnormality, and correcting all your electrolytes really helps. Taking electrolytes, correcting your calcium, your potassium, your magnesium, all those will help. Sometimes you have to use warm bath before, heating pads, all those kind of things. And then there's a whole list of medications that we use for leg cramps. So that's kind of the general field. And one of
I'm
them,
wondering if they can continue asking their questions as we pass out the assessment.
Yeah.
And start filling it out.
yeah,
And still ask their questions.
sure, absolutely.
So
So
that
keep
we can
asking
make sure we
questions. You're
have
going to have the materials be passed out that has the stop bang, and we want to get that going. There's a hand.
I don't know if you kind of talk about the esophageal reflux syndrome or disease.
Gastroesophageal reflux disorder?
Yeah.
Okay, yeah, that's more common with people with sleep apnea. And so that's one of the things that we'll look for is gastroesophageal reflux. The esophageal sphincter is allowing the acid to work back up to the esophagus, and then it can actually go down and irritate the bronchi, and a person can be having apnea on the basis of that. So it's not only an effect, but a cause. So that's something that can be addressed if it's something that we find is actually occurring.
How do you test for that? I mean, how do you, so you know you have it because you can't sleep and And
Well,
it's obvious you have it. I mean, if anybody hasn't experienced it, then no.
Yeah. So you treat,
How do you treat it?
you treat the gastroesophageal reflux.
I mean, I've been to a doctor and they told me try over-the-counter medication for a certain number of weeks, and it still hasn't gone away. So the next step is to do what?
Well, if you've gone through the antacids, and then you go to the acid blockers, that's the Pepsids and the Zantacs, and then you go to the proton pump inhibitors, which is Prilosec or Protonics. Those, and then you get into the prescription grade, the purple, the Nexiums. And if that doesn't work, you should probably go see a gastroenterologist and have an EGD, an esophageal gastroduodenoscopy.
Okay, I didn't realize there is this
Yeah.
scale.
Yeah, it's a little bit of a hierarchy.
Because
And
my fear
acids.
is if you don't take care of it, then that could lead to esophageal cancer as well.
Yes, that's one of the things we look for with the EGD. And that would be something that needed to be dealt with. Yes?
Can you want to explain
Oh,
what they're to do, and there's both sides, and
yeah. The stop bang is that thing that I mentioned, snoring, tired, observed apnea, blood pressure, body mass index, age, neck, and gender. If your score is 3 or more, you need to address that with your doctor. By the way, we will be having you, if you'd like more information, if you'd like somebody from my office to call you to help get you an appointment to come in and see me, I'm happy to do it, and we'll make those available. So if you want more information, or if you want to set up for an appointment, you can do that with this thing that is being passed around. On the back is an Epworth Sleepiness Scale. That's an attempt to objectify sleepiness. You say to somebody, "How sleepy are you?" "Well, I don't know, I'm really sleepy." Well, this gives you some certain conditions. What's the likelihood that you would be sleepy if you were sitting and reading? And there are several: watching TV, sitting inactive in a public place. This is the Epworth Sleepiness Scale. We know correlates to some extent with excessive sleepiness. So there's one on the back to kind of give you an idea of how sleepy you are. And then the stop bang can give you an assessment as to what's the likelihood that sleep apnea is contributing to your excessive sleepiness. If you know that the problem is insomnia and you're not being able to be helped by the non-pharmacologic things we talked about, looking at the nationalsleepfoundation.org and learning about some of the cognitive behavioral therapy things, I'd be glad to see you, or you can talk to your primary care physician.
The nurses are available if people don't.
Yeah, if you don't know your body mass index, there's a chart that if you know your height and weight, you can calculate your body mass index, and we can help you with that. And then there's people to take your blood pressure if you don't know your blood pressure. And we've got some tapes to help you get your neck size if you don't know what your neck size is. Yes?
Do you have to, I tried melatonin, do you have to take that every night at the same time it's listed here? Because I try and take it only when I can't fall asleep,
Okay.
and that's at different times. I take it an hour before I want to go to sleep.
Okay.
Sometimes it works, sometimes I'm drugged in the morning because it's
Yeah.
still in my system.
Okay, melatonin is liquid night. It's actually the circadian rhythm that I mentioned. Circadian rhythm disorders, the biggest drive toward adjusting your clock is light. And light is a very strong, the German word is Zeitgeber, and we have no English word in the English language that's equivalent to time giver. But light, and especially light in the blue spectrum, will push your clock back. Melatonin pulls your clock, and it's a much less robust change agent. But it will pull the clock, so you take melatonin before your sleep. Your best sleep occurs when your body temperature is at its lowest. And so that's usually about 3 in the morning for the 10 to 6ers. 3 o'clock in the morning, their temperature is at its lowest, and that's when they're going to get their best sleep. So if you have an advanced sleep phase syndrome, your clock is more like midnight. Delayed sleep phase, your clock is more like 6 in the morning. So if you're taking melatonin, you want the smallest amount you can take, and you take it before to pull your sleep clock, and then you use light to push your sleep clock. And it's not a good sleep medication per se. It's just a circadian clock. It helps you solidify your circadian clock. And people need to have a regular, a wake-up time is more important than a go-to-bed time. And it needs to be regular. Your body's designed to be regular. It's not just your GI tract that needs to be regular. Waking and sleeping, all those things help. So that would be what I would, does that help?
Yeah.
Yes.
I've got a question. Last time I was at the doctor, I talked about this in Lewiston. And he recommended I try something called valerian root. Have you heard of that?
Yes, valerian root is it's a sleep herb, and it falls into the category of non-pharmaceutical methods. There's valerian and hops and sleepy time tea, and there are a lot of different things like that, and they will help you go to sleep.
Okay.
But sometimes people's need for sleep is such significant enough that the little things don't seem to help. But if you're working on the problem and you correct all the different things we talked about, and like I said, there's a handout on sleep hygiene. Sleep hygiene, you want a bedroom that's dark, it's protected against light and sound and temperature. So, and it needs to be comfortable. Yes.
Okay, people that work night shift, 3 days a week, and then 4 days.
Yeah. You have a circadian rhythm disorder that's fixed. And that is,
And then during days off,
yeah,
even with prescribed medication,
right. It's hard.
doesn't work.
And
I've been known to go for 36 hours straight.
yeah, and you probably have a shift work sleep disorder that's a circadian rhythm disorder. And some people can adjust, and about 20% of people can't. And once you uncovered the fact that you have a circadian rhythm disorder that's fixed, you have to either decide to cut it out because that pay differential is significant enough, but there's only so much you can do. And you're better off to be on a fixed schedule, always working nights, always working evenings, always working days, than you are to be on a rotating schedule.
I've been working that shift for a year and a half now,
Which one?
from 7 to 7 at night.
7 in the morning
7 at night.
to 7 in the morning. And, okay, that's better than working a rotating shift, but if you can't accommodate to it, you're probably trying to change your clock back to your friend's clock during the time that you're off. And you're not really able to do that very well. That's just because the body can't, and the older you get, That's why you don't see the really old emergency room docs, you know. The young guys do that, you know, the adrenaline junkies and, obstetricians are younger looking. Because it's hard to do as you get older. Yes?
A question about exercise. I know exercise can affect blood pressure, BMI, all those things. But is there a direct effect of exercise on
Yes.
correcting sleep problems?
Yes. The exercise increases the amount of time you spend in the stage 3 and 4, delta sleep. So exercise is a good thing for sleep.
How much and how often?
Well, I don't think we have it quantified. We know that the people who exercise have larger amounts of delta sleep. But I think I would give you an exercise prescription based on the amount of, I wouldn't try to do it based on your sleep study. I would just tell you, you need regular exercise, 30 to 40 minutes, 5 times a week as a minimum. And then hide and watch. You know, you're going to find out that down the road, your sleep's better. Yes, ma'am?
You mentioned the melatonin and valerian. Are there any other types of, over-the-counter types of products that you can recommend?
For sleep?
Or even particular brands or anything?
I don't have a list of the kinds of natural sleep. Talking about, there's my sleep tech. He's snuck in, but he didn't come in for a big introduction. Yes?
I noticed you haven't really said what happens when a person does have that obstructive sleep thing and isn't taken care of. It does affect your heart.
Yes.
It can shorten your life.
Yes, it can. Yeah, I didn't go into the consequences of untreated sleep apnea, but they are numerous. I mean, coronary artery disease, breast cancer, things that you wouldn't even normally think of. Stroke, difficult to control, blood sugars. The list is just long, and pretty much all medical problems are made worse by not getting good sleep. And obstructive sleep apnea is the biggest part of why people don't get good sleep. Yes?
Waking up,
Waking up.
not difficulty waking up, but in a 20 workday month.
Okay?
And I'm setting my alarm clock for 6 o'clock,
Uh-huh.
and in a 20-day work month, I will not have my alarm clock go off, but maybe one time in all those 20 days.
Uh-huh.
And I literally can wake up
Uh-huh.
within 7 to 8 minutes of 6 o'clock without the alarm clock.
Right.
And then I can turn that bodily off on weekends and sleep until 7 or 7:30. Now, is there something unique about the fact that you can wake up with that in that really, really narrow envelope between 6 o'clock?
Yeah. This shows you how powerful the brain is. People can decide that they're going to wake up at a certain time and mentally image yourself waking up at that time and go to sleep and wake up.
So that's something good to...
It's a good thing. I would say that's good. I would say that trying to vary the wake-up time more than an hour and a half on the weekend you're asking for trouble. Because if you let yourself sleep longer during the weekend, then you're very likely that long sleep can lead to shorter sleep the next time. And so it can end up with a waxing and waning approach. And so when I'm working with people with circadian rhythm disorders, I tell them they can't do that. They've got to, their bedtime has to be regular. Regular wake-up time, regular go-to-bed time, regular hours, And, you know, if things get to the point where we want to experiment down the road.
So you're advising me to retire again, so I don't have to.
Yeah, absolutely. Yes.
The sleep hygiene here suggests avoid taking naps if you can.
Well, that is if you're trying to get your 7 to 8 hours at night. I mean, you've got the color hair, probably it's okay to take a nap.
I don't use Gritman formula.
Well, I mean, if you can do a regular nap, fine, more power to you.
Well, it's, my wife usually goes to bed about 8 o'clock.
Uh-huh,
The alarm goes off at 5:30 in the morning.
uh-huh,
I usually stay up until 9:30 or 10,
Uh-huh.
sometimes longer than that.
okay,
So I'll usually get up when she gets up and shower and get ready.
yeah,
She'll go off to work and
Yeah.
I may go back to sleep for another hour.
that's fine. You know, you're getting, I did the math as you went through that. You're getting your sleep.
Uh-huh.
And if that works for you and your wife, well, that's great. But that wouldn't be, I wouldn't try to fix that. Unless you had a meeting you were missing on a regular basis and you wanted to, you know, get it organized, then you'd have to do the things we talked about and you'd have to put that. But, you know, that, a lot of times, sleep variation doesn't really need fixing unless it's conflicting with what you're trying to get done other times. I saw a hand over here. Yes.
How long does it take you to go through your rhythm? Your sleep? 1, 2, 3, 4.
Okay, that's a good question. It takes about 90 minutes. 90 minutes. That's the average 1, 2, 3, 4 REM arousal. And 4 to 5 times a night will give you your 8 hours of sleep. So a normal person would arouse 4 to 5 times a night.
So if you're waking every 20, 30 minutes, you're not doing that?
No, you're not doing the whole 9 yards. And so napping is one of those things you have to consider. If you nap, everybody can just take a power nap, you know, just go to sleep, and then when you wake up, you feel alert. That's more of sympathetic stimulation than it is. You're not giving yourself the sleep that you need. You're just powering through. But if you take an hour to hour and a half nap, you're actually contributing to that sleep. So that's an okay thing. Yes.
How long should your naps should be? Less than 30 minutes or what?
Well, depends on what you're trying to accomplish with it. If you're paying off a sleep debt, I mean, if you haven't slept, the biggest cause of a lot of people's feeling like they're walking around with a backpack on is they have a sleep debt. That's unslept sleep. And you need 7 to 8, you get 6, then you got a sleep debt of 2. So the only way to pay a sleep debt is with sleep. It's like a MasterCard debt. It's easy to acquire, hard to pay. So you got to sleep and pay that sleep debt off. So a person might be sleeping 8.5 hours a night for a period of time to pay off that sleep debt, and then all of a sudden they find they don't need that much sleep. They can get by with 7.5 or 8. And that is just paying off that sleep debt. So if you're paying off a sleep debt, you know, that napping might need to be longer. Yes?
Well, in the last year or so, I've read in many articles that say, well, you shouldn't sleep more than 20 minutes, a half hour. It's really, really bad. But that must be for people that don't have gray hair.
I think that, I'm not sure where you read that or
Oh, yeah.
who said it's
I've heard a lot.
bad.
They say not to take long naps.
Well, again, it's a variable thing. I wouldn't put that out as a categorical statement. I think that in some settings where you're trying to get your sleep organized into the nighttime, that you might not want to nap during that period of time. But if you're got the time and you know it's yours to spend, then that's fine. Yes.
What about
You're sleeping fairly well, but you're snoring all right.
That may be okay, but chances are it could represent sleep apnea.
Well, it's not okay for the other person.
No, well, yeah, right. Okay, so, yeah, what about trying to sleep when somebody else is snoring all night? That is, earplugs.
Oh, I got the answer to that, but, I mean, how can you help snoring? Is there any answers to snoring?
Primary snoring can be treated with mandibular advancement device, avoiding the spine position, and those are usually what happens, are ear, nose, and throat procedures. Sometimes there are ear, nose, and throat procedures that can help. I mean, if a person has a deviated septum or polyps, you know, that's the trip to the ear, nose, and throat doctor. And just to be sure that the person's not having, I mean, if they got an S and it's a man, they've got 2 counts against them right to start with. It doesn't take much to go over the road and over the line, and probably need to have a sleep test. And we do, at Gritman, we do what's called an out-of-center sleep test, and that's very inexpensive. I mean, it's actually impossible for somebody to make that particular item profitable. So it's done as a public service. And, you know, but it's being forced to be done by the insurance companies, which they're kind of calling the shots now. So, does that help? Okay. Yes?
What about, what does it mean if somebody is always breathing with an open mouth? Is that a facial structure?
Yeah, probably to some extent. People often, you know, relax, and some people are mouth breathers. And a mouth breather, you know, your mouth gets dry, and you have to use xylitol to moisturize it. But there are, you know, chin straps to keep the chin closed. I've seen some of the things that are designed for treating snoring that go around and look like a ski item. They close the mouth and force you to sleep through your nose, which is good, unless your nose is stopped up. That's not a good idea.
You just die.
Don't duct tape anybody's mouth shut. Yes.
So I hear it mentions light therapy.
Uh-huh.
So I have a little happy light thing you can set, you know, on the counter or whatever. How long do you sit in front of that?
Well, you need to read on the instructions, how many lux is it producing? And you need 10,000 lux. So if it produces 2,500 lux in 15 minutes, you need an hour. But there's some that are really strong and powerful and put out a lot of blue light. Cell phones put out blue light, computers put out blue light, so we always recommend that people have a period of time that they have dim light activities. You know, incandescent light, backlit. The LEDs, any LED light is stimulating the suprachiasmatic and they're lethal. They can really make you stay awake when you don't want to. LED. You know, you've seen the white lights coming at you down the road, and then all the yellow lights and that white one, that's LED. And we're getting more and more LED lights.
That's good, they quit making the others.
Right, they quit making the incandescent light, so that's tough, because that's the best light to use in the night when you're trying to read and not keep yourself awake. Anybody else got a question? And,
I have one more, sorry.
no, that's great.
So my dad has been to a sleep clinic and he said that he doesn't have sleep apnea.
He does.
He does not.
It does not, okay?
Yeah. But anyway, a lot of people, he's sitting in his chair and he will fall asleep and then he will stop breathing for a long time and
Yeah.
wake up and choke and all of that. They say he doesn't have sleep apnea. What could that be if it's not?
Well, that sounds like he's having some obstructive symptoms.
Very clearly.
Yeah. Well, I would want to know if he has any of those other signs or symptoms. I mean, no test is perfect. You know, we do not qualify as, you know, we're not gods. I started out my career with people saying you gotta learn that you're not a god, and I'm ending my career with them saying you're not, you know, I'm worried they're gonna call me a criminal next. Because I didn't dot my I or cross my T. But at any rate, I think it's a matter of clinically, if he's happy and all it is just you're messing up the Seahawks game, well, that might not be as big a problem.
Well, and he snores, I mean, you can hear it 3 rows away.
I would question the diagnosis. You know, again, you know, there are a lot of things that have to be considered, and you know, having, like the gentleman said, you know, he's been in sleep studies, and there's still problems. So I've got some people that I probably hadn't helped, but there've been a lot that have been helped. So I know that there are a lot that can be done. Anything else? All right. Yes.
I come to see you about a year ago, and you set me on the right path, and I've done well. The last 2 weeks, everything you told me doesn't work anymore. What happened? What do I do now?
Well, you know, I don't remember exactly what I said. Sounds like maybe I'd repeat some of it and maybe add something more. We're coming up with new things all the time, learning new things. But it's hard to.
There was that firearm unpleasantness.
Yeah, no, sometimes it's trauma, you know. I mean, it's hard to sleep through terrible things. You know, it's hard to sleep through losses of family and losses of lots of things. You know. Yes.
This is kind of a follow-up to that. Do you ever see it cycle with people where sometimes it's good and sometimes
Yes.
Is it a cycle, or do you think it's more of a result of some sort of environmental, external event?
People do have good days and bad days, and they're, you know, your phases of the moon, who knows what it is, but if you keep a sleep diary and put down the time you go to bed, what you've done prior to that, how long you sleep, whether or not you've napped, whether or not you've taken a sleep aid, all of those things on a regular basis, you'll see that it varies. And if you see something that's real delayed, we're talking sleep delay, real advanced, we're talking advanced sleep phase, circadian rhythm type things. But I mean, everybody knows that sometimes you miss a night's sleep, and the next night you're probably going to get a really good one. And if it's occurring on a regular basis, then you need to get some help. But there's no doubt that people do have waxing and waning of their sleep. And that's not necessarily something you got to do something about.
If you know that you're bothered by light, if you absolutely know that's very true, like even with your eyes closed, there's light in the room that bothers you. Is that probably considered a circadian
Circadian rhythm. It could be if you're having persistent difficulty getting the amount of sleep you get. I mean, some people are certainly more sensitive to light than others, but all of us have that blue light and the blue spectrum can stimulate that superchiasmatic nuclei. That's a physiologic given, and we, you know, got a lot of it going on these days.
So eye covers.
You bet.
I found a sleep mat helps me.
Yeah, good. Yeah, and earplugs are fine. And yes. And
It's on your don't do list, but just how detrimental in either the short or the long term is going into the bedroom at 7 o'clock, propping yourself up, and then watching the TV until 11 o'clock.
That's not a good idea. The bedroom needs to be for sex and sleep, not TV, not doing your bills. You want to have that nesting in relationship with your bed. You know, climbing into bed should be a relaxing, joyful, look forward to event in your life. And if it's not, then you need to work on the sleep hygiene to the point where it is. And that's basically just so that when you do climb into that, you're looking at being refreshed when you wake up. And then it's like, hey, new day, let's go for it. Yes?
One more question, dumb question. Is there such a thing as a vitamin deficiency that can affect your sleep?
Well, vitamin D is kind of one of those non-image bearing functions of the brain. You know, the light comes in and stimulates you to use your vitamin D, make your vitamin D, all those kind of things. So we know that in Idaho, I don't even look for vitamin D deficiencies anymore. I just tell them, you got a vitamin D deficiency, take vitamin D. You know, 1,000 to 2,000.
Any other vitamin deficiencies can affect the sleep?
Well, B12, probably, some of the B vitamins, so taking a B complex is a good idea. The cramp thing, a lot of times B12 can be associated with leg cramps. So,
About magnesium.
magnesium, it's used in repair, so, I mean, it's a good thing to be getting. Most people get it in their nutrition, but 400 milligrams of magnesium, not gonna hurt you. Anybody else? Yes?
What do you recommend for keeping nasal passages open at night when you have chronic sinus problems that clog up your nasal passage?
Yeah, I recommend washing your sinuses with a saline rinse. You can get them at the drugstore. They're basically a squeeze bottle, and you can get a little packet of salt and soda. And I recommend you brush your teeth and wash your sinuses.
Neti pot?
Neti pots kind of use, you gotta pour it. Takes a lot more coordination. I like it. It's a lot easier. The neti pot's, you know, been used for years, very effective. But you just have to be coordinated, not.
So is it okay to do it twice a day, because I do it faithfully in the morning?
I do it twice a day. Do it twice a day. I mean, it's not gonna hurt you. I mean, if you're doing it, you're basically just washing out the effect of the mucous membranes, which that's why they're there. It's a filter, and they do their job, and they filter, and you get dust and pollen and smoke and all the different things collected, and it has to be gotten rid of. So I don't think it's a harmful thing to do it twice a day. Otherwise, then you might be looking at a nasal steroid or some other ear, nose, and throat phenomenon. All right. Well, yes.
I go to sleep fine, I wake up at 12:01 in the morning, and I sometimes can't get my mind to slow down.
Yeah.
So I put my candle on and watch a documentary. Would you recommend that? And I think that helps me go back to sleep.
You put your what on?
Just a little iPad Kindle.
Oh, I see, a Kindle. Oh, yeah. I think they have a phase that doesn't have the blue light. You know, they're dark backlit type thing. Usually we recommend that people, in order to get that sleep, that they get up and go to, I call it a nest, some comfortable place to sit where it's backlit. Or I think the Kindle can be adjusted so you're not getting the blue light. Yeah, but I would, if you're doing it on a regular basis and it's interrupting anything else, I mean, if it's working, and, you know, you're getting their amount of sleep, you're not sleeping during the day, you're not falling asleep when you shouldn't, then, I mean, those are the kind of things you have to look at. Is it the, it looks like there's more food, and hopefully you had some information that will be useful to you.